Medication-related problems in older adults. I completed my pharmacy education and 2 years of postgraduate training at the University of California, San Francisco. I later became board certified in geriatric pharmacy in 2014. My practice experience includes working in a multidisciplinary geriatrics clinic alongside a geriatrician and social worker, medication therapy management in the medical group setting, medication utilization review, and drug information analysis. I have been participating as a clinical pharmacist with the UCSF Care Ecosystem team since 2016. This session will help you be able to understand the physiologic changes that affect older adults, to describe polypharmacy, and to identify potential safety concerns with non-prescription medications. A variety of physiologic and social issues may affect the use of medications in the older adult. As patients age, the way the body absorbs, metabolizes, and clears medications may be altered. As a result of these changes, many patients develop what is sometimes described as medication sensitivity, as they have a different response to or tolerability to medications than a younger patient might have. Older patients frequently require adjusted dosing of medications compared to younger patients. Some medications have a label of being potentially inappropriate by professional geriatric associations. In a subsequent module, we'll discuss what this label means in more detail. With multiple diseases occurring as a result of aging, patients begin to require more complicated medication regimens consisting of multiple medications. It may be difficult for older patients and their caregivers to fully understand these regimens and the purpose and directions for each medication. This may further be complicated by memory issues. As memory and physical strength decline, supervision of medications may be indicated. Physiologic changes occur with aging in all organ systems. Some of these changes may affect the way medications are handled by the body. A decrease in the production of stomach acid, which may occur with aging, can affect the absorption of certain medications that are best absorbed at a particular pH. In addition, certain medications, such as proton pump inhibitors or H2 receptor antagonists, may affect the production of stomach acid and thereby affect the absorption of other medications. The distribution of body water and body fat is altered with age. Body fat increases and body water decreases. Therefore, hydrophilic or water-loving drugs may have a smaller volume of distribution, and lipophilic or fat-loving drugs may have an increased volume of distribution and therefore a longer half-life. A decrease in serum albumin can also affect the free fraction of highly protein-bound drugs, though this change is generally not clinically significant. The liver's rate of drug processing may decrease with age. Drugs that are highly metabolized by the liver may require dose adjustment. Some examples are certain benzodiazepines, especially those with a long half-life such as diazepam. The kidney loses mass with age, and the filtration rate decreases by approximately 10% per decade after age 30. This may result in decreased drug clearance. Calculation of a creatinine clearance can estimate the filtration rate and is used to guide drug dosing in patients over the age of 65. Females have a lower creatinine clearance than males due to lower muscle mass. Since the kidney plays a role in fluid and electrolyte balance, these should also be evaluated periodically when drug dosing is assessed. There is an increased risk of damage to the kidney from certain drugs, so the risk versus benefit of any drugs that may potentially cause damage should be considered before prescribing. In addition to the physiologic changes associated with aging, polypharmacy is a common issue for older patients that may lead to medication-related problems. While there is not a clear definition, polypharmacy is commonly described as 5 or more medications on the medication regimen. The count needs to include prescription medications, non-prescription or over-the-counter medications, as well as supplements. Common contributors to polypharmacy include multiple disease states that are managed by multiple prescribers, a lack of communication between providers, and reluctance to discontinue medications by both providers and caregivers. Side effects from one medication may require treatment by adding another medication, resulting in a prescribing cascade. Frequent review of the entire medication list can help to manage polypharmacy. The purpose and patient's current need for each medication should be reviewed, and a discussion should take place regarding the need for each medication to remain active on the medication list. Unjustified polypharmacy places the patient at risk of poor adherence, side effects, and drug interactions. Non-prescription medications and supplements should be evaluated with the same scrutiny as prescription medications. Many patients consider these to be safer than prescription medications, but they do carry risk. Non-prescription medications may duplicate the role of prescription medications or of each other. One example is of over-the-counter acid reducers available as either H2 receptor antagonists or PPIs, duplicating therapy from prescription proton pump inhibitors or PPIs such as lansoprazole or pantoprazole. Some prescription pain medicines, such as Vicodin or Norco, contain acetaminophen as one of their components. Acetaminophen is also readily available over the counter as Tylenol, and patients may not consider the cumulative dosing effect of both sources of acetaminophen. Non-prescription medications may also result in undesirable effects for patients. Antihistamines, such as diphenhydramine or Benadryl, may result in constipation, drowsiness, or dizziness, which can increase the patient's fall risk. Non-steroidal anti-inflammatory medications, such as ibuprofen or naproxen, that are commonly used for pain, may cause fluid retention, increase blood pressure, and increase the patient's risk of stomach bleeds. Many over-the-counter products are available as multiple ingredient products, and the patient may be aware that some ingredients, such as antihistamine in a cold medicine, may result in undesirable side effects or duplicate other medications the patient is taking. Supplements should be viewed with particular caution as they are not required to have proven efficacy prior to being available on the market. The FDA does not have an approval process for supplements or require them to have the same level of detailed product information as prescription medications. Let's review the key points of this presentation. Physiologic changes associated with the aging process may affect the way the body absorbs, metabolizes, and clears medications. The older adult may need to avoid certain medications due to these physiologic changes or require altered dosing. Polypharmacy is commonly described as 5 or more medications, and a variety of factors may contribute to polypharmacy. Non-prescription medications and supplements should be evaluated with the same scrutiny as prescription medications. This training was supported by a grant from the Merck Foundation. The care ecosystem has been developed and implemented with support from the UCSF Medical Center, the Centers for Medicare and Medicaid Services, the National Institute on Aging, and the Administration for Community Living.